Okay, so let's go ahead and get started, Rosalind, with what you were going to show for this. So we created this test patient based off of an actual patient that Rosalind saw in clinic about a couple of weeks ago. And so Rosalind's going to walk you through this actual case. It's just going to be identified.
Okay, so basically when I'm starting to prepare the survivor plan for the patient visit, I'll start in the diagnosis area. And you can see this first box, diagnosis info. I access the usually the biopsy report in Cerner and get the date of that first biopsy, and then enter the location of where the cancer occurred, the laterality, and then the histology for the tumor. Then under the biomarkers, if this is a breast cancer patient, I'll enter the ER, PR, and HER2 status. If there's an oncotype available, enter that information. The pathology, that staging that we use here is from the surgery, and so we'll access in Cerner the surgical pathology report and enter the data there. If genetic testing was done, we'll enter genetic results under these two boxes. And then there's some additional information under this diagnostic section, family history, smoking history, previous or ongoing medical conditions. This is a little limited. It doesn't obviously offer all possible medical conditions, but check off pertinent conditions here. And then whatever medications the patient is taking, we'll access those from Cerner and enter them under current medications. Any questions on the, I think what I'll do is when we're done going through SurvivorPlan, then I'll take you into Cerner and just show you where this information, where I can find it in Cerner. Any questions on the entering the diagnostic information?
Hey, this is Jennifer. I just have, so at this point, everything that we've seen so far that you've discussed is entered manually by toggling back and forth between the SurvivorPlan and the Cerner record, right?
Yes. No, we do have some of our patients' charts are abstracted ahead of time, and if that's been done, then a lot of the information will already be entered into SurvivorPlan.
Okay.
And then it's just a question of going and verifying that the information is accurate.
Sure.
So a lot of times, yes, this information is already there, but if for some reason it wasn't done, then I enter it manually.
Sure. Got it. Okay, thanks.
Okay. We enter this is just names of all the providers that are involved in that particular patient's case. We include their primary care doctor, and if there's other specialists involved that are pertinent, then we add those as well.
Rob, would you mind just going to the, would you mind going to back to the diagnosis tab and showing them
Sure.
what we're bringing in from the cancer registry in terms of the notes section below, above the family?
Okay, so yes, this patient did have, it was abstracted, so this is the information here under imported notes that we received. And then so that all of that information that's in capital letters came from the abstractors, and then they would have entered, I can't remember exactly what they entered, but anything pertinent from here they have entered into the relevant boxes. But this is how it looks when we receive it from the abstractors. Okay.
Yep, and the med conditions, that list of medical conditions is also imported from Cerner automatically. So that
not this one, not automatic. No, usually this is one that I would enter myself.
I'm talking about right above that. So that little box that says medical conditions from import.
Yes.
Yeah.
Those were imported, yes. Okay, can I move on to treatment?
So the care team is just a list of all other providers that the patient has, correct?
Yes, this list is the medical oncologist, the surgeon, the radiation oncologist. This patient had a plastic surgeon. Then we include the primary care doctor because we send the completed SurvivorPlan is sent to the primary care doctor as well as to the patient.
Okay, and how do these get in here? Do you manually enter them, or how do they appear on this list?
I have manually entered them.
Okay. I didn't know if you were pulling them in from somewhere or, okay.
Well, there is a drop-down list, so I will, through Cerner, I can see, the different consult notes from the surgeon or the oncologist, and then I can go in like this, and so say I'd made a mistake and needed to change it. I have a drop-down list of providers,
okay.
And I just click on whichever is the correct provider.
Okay, got it. So you pick it, you choose it from a drop-down list. You don't manually type it in.
Not all of them, no.
Okay.
Sometimes for the primary care doctor, because they're out in the community, that's often one that we have to enter manually. But all the list of the NCI, exactly.
Okay.
Okay. Then moving on to treatment, we include height and weight at diagnosis, and then the current weight with the BMI calculated. Under surgery, we have a drop-down list for the surgery that was performed, and again here it's been abstracted, so I have the information right there. So it's just a question of I'll go to the operative report and just confirm that it is the correct surgery. Number of lymph nodes that was examined and number of lymph nodes positive. That's entered on these lines. Then we move to, if the patient had radiation, in your institution, is all your radiation done through ARIA?
Yes.
Okay, so same with us. They use ARIA. With Cerner, often the radiation information is scanned into Cerner, so often I can access it in Cerner, but if not, I will go to ARIA to get and use the treatment summary page to get the information on the total dose of radiation, the number of fractions, and the start and end date of radiation.
Okay, so there's a page in, Sandra, this might be of interest to you. There's a page in ARIA that's called a summary page for radiation.
Hello?
Are we still all connected?
I can hear you.
Okay, good. There's a page in ARIA called radiation summary or treatment summary?
Correct, yes.
Okay, all right.
And so we just we'll work from that that's what we consider our, most accurate source. Often there is a treatment summary scanned into Cerner, but if I have any, concerns, I go directly to ARIA and to that treatment summary page. That, is pretty much guaranteed to be accurate.
Okay, thank you.
Okay, for the chemotherapy, again, we have a drop-down list of the different regimens to choose from. This particular patient had the TCH with pertuzumab. We enter the start and end date and when the chemotherapy was given. And then below that, there's a box to enter the number of cycles of each drug that was received and if there was any dose reduction. We recently added a separate box for immunotherapy. This particular patient was on Herceptin, so again, it was the same start date, and then just documenting that she was going to be on the Herceptin for the full year. And below that, for hormone therapy, this particular patient did not receive hormone therapy, but we put, if they are, it's the drug dose, start date, and the planned duration. And then at the end, there's a very nice timeline that shows here was her chemotherapy. There was a Herceptin start date. This is when, so she had neoadjuvant chemo. Then there was the surgery, and then she received the radiation. These were the dates of the radiation, all showing on the timeline. Below
so
that, if there were any,
your chemo regimens are built out in Cerner for you?
Yes.
Okay.
Okay, and then any treatment-related toxicities, we can just check these off on the boxes here.
So whenever it says notes from import, by the way, where it's all caps, that means that we imported the notes from the cancer registry. And also where it says surgical events from import, that's where we imported the surgical events from Cerner. And then a lot of that data, those discrete fields underneath in each section are coming from the cancer registry if the case has been abstracted. So in your case at Baycare, if Deb had abstracted the case, those fields would be filled in, like the definitive surgery date, the number of lymph nodes removed, and so on.
Okay, got it. Sandra had a question earlier, but we couldn't hear her.
Okay.
She looks like she's muted on the participant list, but she was trying to ask a question, but we couldn't hear her. Sandra, do you want to try again?
I think she muted herself because we didn't mute her. Let me see. Now she's unmuted. Let's see. Are you there, Sandra?
Sandra.
I'm also on my phone, so can you hear me now?
Oh, yes, great.
I can hear you, yep.
So I guess the computer also mutes my phone for some reason.
Okay.
But, no, the only comment I was making earlier is that, yes, there is a treatment summary in ARIA for the radiation therapy.
Yes.
Okay, great. At this current time, do you scan that into the Cerner record?
We do not.
Okay, I don't think we do either, but that's a question for RadOnc. Okay, thank you.
Mm-hmm.
And something that I just want to mention, too, is that we're working to get the data from that ARIA treatment summary through the data warehouse at Baptist Health South Florida. So we're actually working on that right now, so that data will come from ARIA more directly than from the cancer registry abstractions.
Okay, thank you.
Okay. Now, Elaine, did you want me to go into the next part, like for the surveillance and the side effects, or just go now to Cerner to show where we find the information?
This is Sandra. Can I clarify one more thing first?
Sure. Mm-hmm.
On the summary from ARIA for radiation therapy, we do have a doctor's note that is dictated into Cerner and is available to Cerner, but the actual form that's in ARIA is not scanned into Cerner. So it is in both in one form or fashion, at least here at St. Anthony.
And we often see that too. There'll be like the last visit there'll be often a note with the treatment summary that's scanned into Cerner. But like I said, if that's not available for whatever reason, going directly to ARIA to the treatment summary page is where we get the accurate information.
And Roz, I was just going to ask if you could show them also the screening results that you see for the patient, since, this patient did actually in reality have the NCCN distress thermometer distributed and the Ross Pro.
Okay, so yes, this is the screening results page. So each patient will fill out the distress thermometer score before I go to see them. And then it's entered here, and this can be tracked over time. And then on the Ross Pro for pain and for fatigue, it can be documented in here as well.
And if you click on that little arrow, it'll show any of the positively endorsed symptoms that she has, which is actually, I think, what you used in creating her plan. Because you added lymphedema and weight management as problems in her plan.
Yeah. Okay. Elaine, do you want me to go into the plan or go to Cerner now?
I mean, if you were doing this in real life, what would you, in advance of the visit, what would you do?
Well, sometimes I will go into the plan and start entering information on the surveillance schedule that's recommended for the particular patient, just so that I have that ahead of time. So, for example, for medical oncology, this is the tab. There's the standard follow-up, and then often what I'll put in here is when the patient is next due to see the oncologist, and I'll mark down the month and year that they're due for their next visit. That's not, I don't always do that ahead of time, but if I'm trying to be really organized and have everything ready when the patient comes in, then that's something that I will sometimes do in advance.
So I just want to make sure I was reading that correctly, or I was interpreting the information correctly. So if I was presenting this to a patient, I would say, your medical oncologist wants to see you 6 months. Let's just say their treatment ended yesterday and they came in today for a visit. So they want to see you again in 6 months. And then you would tell them that, during your, 1 to 2 years out from your diagnosis, they want you to be seen every 3 to 6 months. And I mean, is that how you roll it out to them, or how do you discuss this page with them? How would you discuss this?
So we just, we just speak with the patient. Often I will have looked at the, at the oncologist's previous note and what they've said, from that last visit about when they next want to see the patient. And it does depend, typically if the patient is on, an aromatase inhibitor or tamoxifen. If it's a breast cancer patient, they'll be followed more frequently in the first year or so out. So most likely it would be every 3 months in the first year, and then I would, I can change it as needed for the individual patient. So I could change it to every 3 months. And then let the patient know that, the oncologist will guide them and let them know what the frequency is going to be as they move beyond the first and second year into years 3 to 5. But this is just sort of a standard drop down that we have available for breast cancer.
Okay, thanks.
Okay. And then, yes, we can do the same for the surgeon. If the radiation oncologist has a standard follow-up or needs follow-up on this particular patient, we can enter that as well. If they had lumpectomy, we'll put in the recommended mammogram screening frequency. If it's a lumpectomy, I'll change this to say every 6 months for the first 2 years instead of annual. So there's a lot of versatility in terms of being able to change it and customize it to the individual patient. And same thing here, I would change, if it's a lumpectomy patient, I'd change that to every 6 months. And then write when it's next due so that when they first get, if this is, ideally we're seeing the patient shortly after they finish treatment, so they'll have it all in one place as to when their next surveillance mammogram is due. Okay, and then this section here is, again, working off of the review of systems and whatever else we discuss in the visit. I can click on these different treatment-related effects. And, for example, if I add anxiety, there's a lot of information preloaded into this box, and then I will customize it for the patient depending on what I want this particular patient to do. If I'm recommending medication or if they happen to already be on medication, then I can remove or add as needed to this area. And then if there's going to be I'm sorry?
Was that a template for anxiety that you all created to have in there?
Yes,
or?
That's right. Yes.
All right.
Correct. And then, again, for the appointment follow-up or if we've made a referral, so this patient, if I refer her to a psychiatrist for her anxiety, there will be an appointment set. And when she gets her survivor plan, she'll, know to look at her list of new appointments for when she's going to see the psychiatrist. Same with, obviously, with BMI, often above normal range. This is one that we're commonly working with. So we have some information already entered, standard information that we created, and then they can be referred to the nutritionist or to the exercise physiologist, and that box will be completed as well. Any questions on this section?
Beth, do you have any questions?
Any that I think of, you've already asked.
All right, sorry, thanks.
No.
All right, and then there's another section for possible late effects of treatment, and often this is, if the patient received chemotherapy, this will be pre-populated and checked off, and then I can, add or remove as needed, and then the same for if they've received radiation. A lot of the possible late effects of radiation will be already checked off when I go into this section of the plan. And I will, again, customize that as needed. And then under wellness prevention, we can have our recommended screenings for other cancers, if they need colonoscopy screening, if they need cervical cancer screening, if they're a smoker and need lung cancer screening. These can all be checked off and information added as needed pertinent to the patient. And then in this section here, there's just some general information on recommendations for physical activity, for healthy diet, alcohol, tobacco, sun exposure, standard information on all those different areas. Okay, and now have you folks seen what an actual survivor plan looks like once it's been completed?
No, I haven't seen one. We'd love to see it.
Okay.
Yes,
Okay, let's just pull that up. So this is now how the plan, I can have a clinical plan view, which actually is very helpful when I go to complete my Cerner note for the visit. Let me just go into the clinical plan. So the clinical plan looks like this. And what I can do is copy and paste from this section into my Cerner note, and it gives a very nice HPI just in sort of very standard form that shows the diagnosis date, the treatment that they received, and so I don't have to retype it when I go to do my Cerner note. And then, so that's the clinical, and then what the patient will actually receive looks like this. And there's the timeline, and then this is their schedule of follow-up visits, all in one box here. And then the recommendations for the mammogram, for what sort of recurrent symptoms to look for, and then whatever treatment-related effects that they're dealing with. This is the section here. There's the possible late effects, and then the general wellness and lifestyle recommendations in this section. And then at the end, their list of care team members with all of their addresses and phone numbers. And then there's a list of web resources pertinent to their particular tumor type.
And where is their list of scheduled appointments?
Okay, let me go back to that. Okay, this section here, so the medical oncologist. This is one that we duplicated from a patient that I had seen, and not all of the information came across. So, but this is what the boxes look like. So the medical oncologist, if I had put in the actual date of that or the month of that next visit, that would appear here under when. For the mammogram, if they're needing mammograms, and again, that date that I entered will appear here. And then these are the different referrals that I would have made in the visit.
Uh-huh.
And then this is the recommended follow-up, that they should see their primary care physician at least once a year. And if they were needing a 2D echo, that would be either under the primary or under the medical oncologist.
Okay, and where it says, like for physical therapy, nutrition, it says see scheduled appointments list. Where is that list?
Right. That would be what they would receive as they walk out of the clinic. They go to our front desk, they make their appointment with our nutritionist or psychiatrist, and then they're given their list of follow-up appointments through our department. These are within our department.
Okay, got it.
Okay.
All right.
Oh, so can I just insert one thing here? So for each of those things, it either says see scheduled appointments list or it says patient to make appointment. That's going to be based on your workflow. So we customize this for every single one of those building blocks according to how you guys are going to do it at daycare. So like if that's it or someone in scheduling is going to help them schedule it right then and there, it would say see scheduled appointment list. if Beth is just going to tell them, here's a referral to, you know, here's someone that you can make an appointment with, and it's up to the patient to make that appointment, it would say patient to make appointment. But it basically can say whatever you guys want it to say. I mean, it literally can say whatever you guys want it to say.
Right, like this one with the 2D echo at the bottom says patient to make appointment. Yeah.
Okay, I was just curious because when I kept saying see scheduled appointment list, I was expecting to see a list at the end of the document, but that's something that you would hand them after the appointments were made as they exit the
Exactly, for those
center.
particular ones, yes.
Okay, all right.
Okay, any other questions?
Question. Can you hear me all right?
Are you going through the plan with the patient? Are you using this view of the patient plan when you're, you know, when you're talking to the patient, or are you using like the screens on the dashboard when you talk to the patient?
I'm in the on the dashboard, yeah, on this view. So if I'm discussing, you know, weight management with the patient, then I can open this up and be showing the patient, you know, talking with the patient as to what I'm recommending, and then typing in as we're speaking, you know, the recommended interventions or medications. But typically, I don't typically fully finish the plan during the visit. Occasionally, if it's a very straightforward and you know, brief with not a lot of issues, sometimes I will finish it right then and there and print it and give it to the patient as they're leaving. But the majority of the time, you know, I have it maybe 75% done, and then I finish it at my desk, and then it gets mailed out to the patient by our coordinators. But it is very interactive, and yeah, you know, we walk through each of the follow-up visits. You know, a lot of patients are very on top of, you know, knowing what their schedule is. Some of them are like, oh no, I'm not sure when I'm supposed to see the surgeon next, and so we'll discuss, you know, what the recommended frequency is, and if they don't have an appointment, then that's also something that will help them with getting it scheduled as they leave, or having them call the surgeon's office to make sure they get the appointment set up. Hello?
Yep. Did anyone want to see this in Cerner, or are you guys all kind of familiar with where she would be going in Cerner to find some of the information for the diagnosis and treatment?
No, I'd like to see some of the Cerner.
I would too.
You'd like to see Cerner? Okay, sure. Let me just see if I can pull this over and pull up Cerner. Okay, so this is a test patient. Obviously, this is not the same, unfortunately, not the same patient that we were working from. But if I'm starting to, you know, prepare the chart and I need to access the pathology information, say from the biopsy or for the surgical pathology, then I go into results review, go to pathology. I have to enter the date range, and then I can pull up the pathology report in this section to confirm either, like I said, either the biopsy or the surgical pathology. That's where I'll usually find that information. For the chemotherapy, I go into oncology, go to the oncology flow sheet. Same thing, I have to make sure I have the right date range, and then this is just, again, a test patient, but it's showing that they received this. This isn't actually chemo. And then so whatever the chemotherapy drug, click on it, and then you can go to this little graph tab and click on that, and then whatever the regimen was they were receiving, you can see and confirm the start date and the end date through here. And then also going across here, the actual dose that the patient received of the chemotherapy drug is available here, so I can confirm it from this screen as well. And then obviously for the, if I want to see the operative report, going down under the notes section for operative notes, I can get that there. I work a lot from the oncology consult notes. So again, all of this is available through here. Pulling those up. And the radiation, like we said, is sometimes available in Cerner, or other times I'm going to be logging into ARIA to get that. And yeah, so that's basically the. So there'll be the abstracted charts that have, like I said, have that information already entered, but just to be doubly sure, I always go back and actually check the pathology directly in Cerner from the report and make sure there's no mistakes.
So where would you find like the side effects that you had documented on the patient?
The active side effects those are from what the patient listed on the review of systems form that we provide to them. The MAs give the form to the patient and they fill that out themselves. And we have a review of systems that's specific to each tumor type. So the breast cancer review of systems has a list of possible symptoms that are specific to to the chemotherapy and specifically to the aromatase inhibitor potential side effects. And the one for genitourinary would has a different set of most common side effects that they are likely to experience. Sorry, what was your question?
Is that scanned into Cerner, or?
That will be scanned into Cerner at the end of the visit, yes.
Okay, so where would we find that?
But in SurvivorPlan, if you could go back, she was showing you in SurvivorPlan where that's getting entered into screenings. So on the screenings tab, there's on the main dashboard, there's a, I think you need to scroll up on the right, yeah, there you go, and then go back to the, yeah. So when she clicks that little arrow, or if she clicks view, she can see everything that they entered into that. If she clicks view, she can see the whole thing.
Okay, so yeah, so that was
entering it into SurvivorPlan?
No, the patient is completing it on a paper form. There's a form with a checkbox, and they complete that, and then that's given to me when I walk into the room, and then discussing with the patient, will go through that list of side effects that they've endorsed, and then discuss what the treatment recommendations are to manage those side effects.
Oh, so that's done at the visit. You're entering this like with the patient.
Exactly. Yeah.
Oh, okay.
Yeah, and they're actually using MAs to enter it from the piece of paper into SurvivorPlan as discrete fields, and then they're scanning it, the completed one, into Cerner. But if she clicks, and then this is actually helping them to keep track of kind of the prevalence of certain symptoms across their whole patient population. So we were able to kind of, be able to help them understand what's the prevalence and needs of like their breast cancer survivors based on what patients are reporting.
Do you have any other questions that I can help you with?
Does B-Test, I think B-Test Jose has a completed SurvivorPlan. If you go under documentation in oncology survivorship.
Yeah. Mm-hmm.
So all those tabs in that folder are the survivorship plan just being updated?
This is just a test patient. I think this may have just been entered a number of, let me just see. This isn't an actual patient, so let me see what the other ones are.
I was just curious.
Yeah. We normally will update the survivor plan once a year. And so then we would, we have all the basic information already available, and if the patient comes back at the 1-year mark, we will update or change the information as necessary and then send the patient the updated survivor plan.
Okay.
So if any, if they had developed any new side effects or any new issues or something had changed in terms of additional treatments, that can be added in at that time.
What do you do with the survivor plan if, let's say, the patient relapses after or progresses after the first 7 months out of treatment?
Well, at that point, they would then have to go back into active treatment, and depending on what what type of recurrence or issues that they had developed, they might no longer continue in the survivorship program if they had gone on to, say, a metastatic cancer at that point.
Right, and where would you document that?
That if they came to see us and that had been the occurrence, we would document that in the Cerner note. That the patient was going to be following up for additional active treatment with their providing oncologist or surgeon or whatever the needs were.
So well, I'm just thinking. So I'm thinking out loud, really. So I'm a breast cancer patient, and I've been given my survivorship plan last month. And in 3 months from now, I notice a lymph node enlargement, supraclavicular, and I go have that biopsied, and in fact it's disease, and I come back to see my original oncologist, and they put me back on some kind of treatment. Am I being told as the patient that, no, your survivor plan was, for the time that you remain stable or disease-free or whatever, and going forward we'll have to, regenerate a new one, and where is that documented in the records so that the patient is clear that really that survivor plan is really no longer applicable right now, and we've gone on a different track. Do you understand what I'm asking?
Yeah. I think it would be sort of managed on an individual basis. If they received additional treatment and then completed that and were cleared again and stable, they could come back into survivorship and receive an updated plan that did document the additional treatment. But if it was a progression into a stage 4, at that point they would probably not continue through the survivorship program.
Got it.
I think it would be very much based individually on what the new issue was and what the oncologist or surgeons were recommending in terms of treatment at that point.
Okay. And I'm not sure that this is the forum for the question, but we have a lot of Creole and Spanish-speaking patients that don't read English. How would we present them with a survivor plan in their native language? Have you overcome that barrier? I know you guys have the same issues.
We do have a lot of, not very many Creole speaking, but a lot of Spanish speaking patients. At this point, we do not have it available in Spanish, unfortunately.
Okay.
So it's provided, the plan is provided to the patient in English.
Okay.
Right. It's definitely on our roadmap to create. So right now we're just still creating all of the content and, for every one of the 10 diseases that they see there.
Right.
So once we roll out all the diseases, then we can go back to all the content for all of the long-term effects of every cancer type, and those would be translated. All of that patient education that she showed you would be translated into Spanish.
Okay.
in those templates, because it's really just a template for every building block.
Right. Beth, Deb, Sandra, you guys have any questions? And Anna, are you thinking out loud?
I'm just kind of listening and taking it all in.
Okay.
Same here.
Okay, Elaine, I have Gladys available. Did you want Gladys to come on now and show some of the the issues that the coordinators deal with?
Yeah, that would be great if Gladys is there.
Any time that she's available, whenever you'd like her to do that.
Yeah, that would be great if she could come on.
Okay.
She could,
all right. Let me just
swap.
I'm sorry?
Are you just going to swap the phone?
Yes, yeah, she's just going to come to my desktop. Yeah, she's right here.
All right.
Okay, all right. So I'll stay available, but she'll show you her piece right now, okay?
Thank you so much, Roz. We really appreciate it.
Hello.
Hi, Gladys.
Hi. Okay, so basically I check the Survivor plan here in Google Chrome. Let me bring it up.
So Gladys, this is Jennifer from Winter Haven Hospital. Can you just tell us a little bit about your role and what you do as a coordinator?
Yes.
Just very brief.
No problem. We basically qualify all the patients who are being referred here to the survivorship clinic. We screen all the patients. We go through Cerner. We check all their records and make sure that they meet the criteria. We also scanned the Survivor plan into Cerner. We mail the Survivor plan out to the patient as well. Basically, those are my role.
Thank you.
Are you guys helping to get the patient scheduled too? Are you still doing outreach or no? Okay. So
we do.
Outreach.
Yeah. We call all the patients who are being referred. We do.
Okay. And you call them and help get them scheduled, and then.
Yes, we do. Yes.
Okay.
So I go here in Google Chrome, and I go to the Survivor plan, the patient. I check to see if the patient's in the drop-down. If their name is there, then they're coming in for an appointment. So I go there, and then on Cerner here, I go under Oncology Survivorship folder, and here's the link to the Survivor plan. So from here, I'm going to save their Survivor plan, and we print it from here. Elaine, you want me to go through the steps on how we scan that into Cerner?
So the only thing I think the part is that you're doing that for the patient portal, right?
Yes.
So to get it into the portal right now,
correct.
The way that
yes.
it works in the IQ Health documents in the portal. Yeah.
Yes.
So yeah, that'd be great to show if you could.
Okay, so I just click on the link. It comes up here on the PDF. From here, I print it. That way I have it here to mail out to the patient. So I just save it as a save as. Here. And I'll save it to the C drive, and I just make sure I delete that at the end of the day. And I save it here. She doesn't have a PDF folder. Okay, well, on my computer, I have a PDF folder here. Let me just put it here.
But I don't have it.
Okay. So when I go scan it, I just hit the scan button here. And then here I'm going to create the Oncology Survivorship Care Plan. And it's not here. The folder isn't here. Under here, there's usually a Oncology Survivorship Care Plan folder. So I would select that. I would put the APP's name up here, who saw the patient. the data on the survivor plan, and I would hit import. Then that creates the folder for the patient portal and Cerner. But for some reason, it's not available here. It's normally under here. And then it would pop up under here. There would be a subfolder here that would say Oncology Survivorship Care Plan. So the link would still be here, but then there would be an additional folder here where you could locate the survivor plan and Cerner. Anything else, Elaine?
No, I don't think so.
That's pretty much.
At Winter Haven, are your patients using the patient portal? Are you guys putting like lab results and test results and appointments up on the portal for them in Winter Haven?
We are.
Okay.
I'm not sure all of them access it, but Beth, what do you think?
I was unaware. I know that they can get like their lab results and things. But
I think they usually just, when they want their lab results, they just ask for a printout. I don't think they actually go through this whole process of saving it as a PDF and scanning it. I don't even know if they have the availability to scan it.
No, but I think what I'm asking is, do patients access their portal?
We have some patients who will tell us their labs are back before we get the report that their labs are back. But we don't do anything in Cerner for that. It automatically populates the lab.
Right.
Usually when patients get patient portal, it's like when they go to the first admission process and they sign up with their, if they provide their email to when they get admitted or start that, but if they don't, then it's really hard for patients to get signed up for patient portal. There's phone calls made, so I think it's really underutilized.
Okay. Well, that's something we need to improve on. Okay. Thank you.
Okay. Yeah, and just to clarify, what Gladys was showing you is not what the patient would do. She was showing you what the coordinator does to make it available in the portal.
Right.
You only have to do that if you want to make it available in the portal. If you don't want to make it available in the portal, you don't have to do anything. It's already right there in Cerner. But the part of what Gladys and her colleagues are doing as coordinators is making it available in the portal as well.
And it's in a separate folder, that way it's easy to access.
Right, it's in a separate folder that's mapped to ID Health documents in the portal, and that's just because they didn't want all their progress notes being viewed by the patient, so it had to be a separate folder that the patient could see anything that's in that folder. So I think that's it from the...
Yeah, basically that's it.
Yeah.
Thank you, Elaine.
Thank you. Thank you so much.
Okay, thank you.
Really good. Appreciate it. Is Dr. Courier on the line too?
Yes, I am.
Hi, Dr. Courier.
Hi, how are you, Elaine?
Good. Good. I think we're finished with the demo part, so if you had any information that you could share, that would be fantastic.
Well, I just jumped on a few minutes ago. Who's on the line, please?
Rosalind, I'm here.
Okay.
So this
and
is
from the Winter Haven group?
Yeah, this is Jennifer Neff. I'm the Director of Inpatient and Outpatient Oncology Services, among a lot of other things in the hospital, but I have with me Anna Giles, and she's the Assistant Nurse Manager for Inpatient and Outpatient Oncology. And we have Beth Burgess, she's our Oncology Nurse Navigator, and Deb Schulte, she is our Manager of our PANTHA Data Registry.
Oh, terrific. Good afternoon to all of you. So Elaine asked me to mention to you all what the process has been, what have been the successes and the pitfalls, given that this has been a long process for us. Here at Miami Cancer Institute, this is the first time that they've instituted a survivorship program, and I'm assuming you all are in the throes of doing such at your facility?
We are. We have 4 cancer programs across our system, our hospital system, and everybody's doing something a little different. Some people are using the Journey Forward. And Sandra, what are you using?
We're using Journey Forward here at St. Anthony's as well.
You are, okay. And so we want to standardize, but we also want to look at, you know, the different things that are out there. And the Survivor Plan really was the first thing that I've seen that I thought was the most complete, most user-friendly, most understandable from a patient perspective. And also, I liked that it interacted with Cerner, which we have, and we also have Sorian. So we were hoping that, that this would be a solution for us.
So all 4 of your hospitals are on Cerner?
Our whole system is on Cerner, yes.
Oh, terrific. Okay. Well, I'll just give you a thumbnail sketch of what our experience has been. First of all, we did 2 years of due diligence looking nationally at different companies that were developing or had developed software programs for survivorship care. And hands down, there was no other company that we really felt had a product on the market that would handle the scope of services we wanted to deliver in our survivorship program. I think many of them were more tailored towards navigation or kind of this concept of checking the box and giving you your survivorship care plan, and we've fulfilled that criteria, and good luck. So when I met Elaine and her team, it was clear to me that, you know, she was a person who can think outside the box, was very collaborative, and very knowledgeable, given her experience that she had had at Emory with the transplant service. And as you all know, transplant medical services are probably a model very similar to oncology, where you really have a lot of multi-specialty collaboration. And so I thought that was a good groundwork for her to be able to work with us with our oncology population and all the specialties. It has been a very fruitful courtship and collaborative effort that we've had, and she has been on point and very responsive to all of our needs. We have been very happy with the product she's helped us to build. And we also wanted to make sure that we had a standardized instrument, but most importantly, something that could be edited in real time and at the point of care. Many of these other survivorship softwares are, you know, very static documents and not dynamic documents. And because of where we wanted survivorship to be in terms of more of a long-term, ongoing healthcare document, we needed something dynamic. And the fact that we were able to truly customize, we wanted it to be comprehensive, but relevant to the patient. And many of these other documents were just kind of generic, very general statements that I personally did not feel was helpful. And if I was a breast cancer survivor, I would think a lot of that didn't apply to me. So the fact that we're able to customize this and update it with ongoing randomized clinical trial outcomes to stay at the cutting edge of treatment recommendations was absolutely critical to us. So it's truly been a game changer in terms of delivering very customized and tailored survivorship care plans to the patients. And inevitably, everyone that has come through that program, I get very positive feedback from the patients that this was a very worthwhile clinic for them to engage with. And many times they've said, you know, I came here kind of reluctantly because I thought, what are they going to offer me? And now I'm so glad I came because this is truly a game changer for them in terms of, you know, really giving them a roadmap to recovery with these documents and the ongoing clinical care that the APPs provide to the patients. In terms of, are there any questions regarding, you know, kind of the formatting or anything or the unique functionality in that you can edit it at the point of care. Any questions about that? I'm sure Roz covered it in detail with you all. But to me, that was a very important feature.
Yeah, so this is Jennifer, and she did cover it very well. And the fact that my attention was first drawn to every box, blue box that had an edit word in it. And almost every section had that. And that's so important because if you've been in the field of oncology, you know how often things change. And so that was really important. That was very, very important because it is a fluid document, because we're talking about humans, not, you know, a production of a piece of equipment. These are human beings that we're treating. So that was really important to me as well.
And so in terms of rolling this out, so it sounds, Jennifer, that you've been in the oncology world for a while. So you know that, okay, so you know that this is going to be a huge cultural change for the oncologists to start giving up their patients to survivorship care. And that is going on nationally. It's not unique to our center. It's not unique to your center. This is a national phenomenon that there's reluctance to give up the patients to survivorship care. So what I would recommend is, as you're getting ready to roll this out, number one, you need to get the buy-in from your leaders in oncology, in med, surg, and radiation oncology, and certainly your CEO of the cancer center or the healthcare system that you're working at. Without their buy-in, it's going to be a real challenge. And also, I think a process to help you facilitate that buy-in is to start meeting with the different disease site groups to start to develop the consensus for their disease sites in terms of what their surveillance guidelines should look like. What should the schedule look like? What types of testing are we going to start doing so that they feel they're part of the process? They're more likely to buy in on it at that point. And then what I would recommend is, once you get this rolled out, if this is the product you're going with, is to focus on one disease site at a time. And in our experience, the highest utilizers are the breast cancer survivors. They have the largest litany and spectrum of clinical needs after treatment, and they're truly your high-end utilizers for survivorship care. So get your champion and med-onc for breast cancer, get their buy-in, and do it one disease site at a time until you really build the following that you need. We have, it's been a challenge to get the referrals coming in because it's really not something that's on their radar. And if at your system the oncologists are partially compensated by RVUs, that's going to be another hurdle in terms of taking their well patient visits into your clinic, right?
Yeah, right.
So the one way that you can help to do that will be to embed your survivorship clinicians. Are they going to be nurse practitioners, nurses? Do you know yet who's identified for that role?
We haven't crossed that bridge yet.
Okay. Most centers use mid-level providers for this.
Right.
So I would tell you that perhaps a good strategy, and what they started with at Memorial Sloan Kettering, was having one of the nurse practitioners that was embedded in an oncology disease site allocated as the survivorship clinician. And if you're embedded in the oncology clinic, it's easier to identify eligible patients, see them in that same oncology clinic for your surveillance visits, so that the oncologists still feel that they have partial ownership of that patient. And I think that would facilitate referrals within your survivorship program. And you may find that initially it's going to be a co-managed model, whereby the oncologists want to continue seeing them for the surveillance visits, to order the diagnostic scans, and to review the surveillance results of those scans, but that survivorship appointments will really focus on all the other needs of the patient related to their cancer treatment, really monitoring for the late or long-term effects and treating the long-term effects. But many times the oncologists want to keep their hand in the pie in terms of seeing them at least once a year, and perhaps the survivorship program can see them every 6 months. So the survivorship people will see them Q6 months, and the oncologist will see them once a year. And that may be the best way to negotiate bringing survivorship into your center. And gradually, I think, and we've seen that now finally here after a year and a half of this, that the oncologists are willing to start referring them without the co-management. They'll let us handle it as they're getting busier and busier. But it's really about finding your champion in breast oncology and starting there. And then, however, if you have champions in any other of the site disease groups that are advocates for survivorship, certainly tap into them. And at the end of the day, your best incentive for referral will be the patients going back and telling the oncologist, wow, that was great. I wish you would have referred me sooner. And that's what we're getting. That's the experience that we're having here.
Okay. Sounds good.
Also, in the order sheets, the order pages for oncology, make sure the Cerner people create an order for survivorship referral built into their order pages, so that that's an easy order for them. You know how you can format it on your routine orders? You want to make sure Cerner does that for you guys.
Say that again.
They format, on Cerner, they format the way the orders look for the different oncologists, and all the different physicians have different order sheets that are kind of customized to them. Make sure Cerner places on that format referral to oncology survivorship in order, so that they're just clicking on that as they work through their workflow.
Okay.
And the other thing that's been very helpful, too, to identify eligible patients for survivorship has been to have the medical assistants who work in the oncologist clinic start to identify eligible patients on their patient schedules every day. And that way, whichever survivorship clinician you have embedded in their clinic can pretty much pop in to see the patient to let them know about the survivorship program.
Okay.
So that's another way to capture patients. But it's really about starting the referral process. And lots of different mechanisms you can try. These are the ones that have worked for us at our institution. But it's a cultural change, so just be prepared. You got to be persistent. You have to stay the course, and gradually the referral practices will increase for you all.
Okay. Good to know. How, I guess, how passionate were your surgical colleagues in gaining consensus on your surveillance protocols?
They were very involved. What happened is our disease site tumor boards and administrative meetings had representation from surgery, radiation, and med-onc, okay? And initially, there was a lot of bickering back and forth because everyone wanted a piece of the pie for RVU reasons, right? They wanted those visits. And we had the docs saying, radiation was saying, well, we have to see them every 3 months, so was surgery, so was med-onc. So essentially, they were trying to schedule the same patient every 3 months across all 3 of the specialty areas. And so you need to negotiate with them. And the way you can negotiate with them is by bringing in the team leader or the chief of medical oncology. And that's why I'm saying it's very important, Jennifer, to be doing your backdoor lobbying with the chief of medical oncology and surg-onc and rad-onc to come up with a surveillance schedule that's reasonable for the patient. This has to be patient-centered care. It's not physician-centered care. And so it was a process. It took me 6 months of going to these meetings and, you know, trying to explain the patient's not going to come to 3 visits every 3 months with all 3 of you. And we need to come up with something. And so what we finally came up with is that the surgeons were willing to see the patient only one time at the 3-month follow-up, and then they were willing to give it up to med-onc. Radiation onc was also willing, but I'll tell you, this was not something that was reached quickly. It was a process. So you got to have leadership in there. You need the head of each of those divisions to be supporting you all when you go into this. And at times it got contentious, but, you know, gradually it worked itself out. But that's why I'm saying you got to stay the course. You really do. And you need to be flexible, too. And you can say, okay, let's try this for the first 6 months, but then we're going to revisit it. And many times the patients will complain, and what they'll tell you is, I don't want to see Dr. Jones. I'm there for 2 minutes, and I really didn't get much out of that visit. And they prefer to come to survivorship.
Yes, I've been hearing that for 30 years. Why do I have to go to the surgeon and the radiation oncologist and the
right.
Yeah.
Right. Yeah. And, you know, part of it is what has helped us is as more and more new patients are trying to get in, our approach has been, if we don't get in a new cancer patient within 72 hours, we've lost that patient to our competitor. So you have to have open slots to see new patients, which are much more higher acuity, higher RVU weighted visit, and let us take over some of your wellness visits so that you can see more of these high acuity. And when they start to see that there's a wait to get in to see them, what happens is your administrative leadership starts talking to the docs about that too. And that helps to, you know, encourage the referral practices also. But it's a very, you know, what you're looking for is it's almost like a perfect storm. You have these political, economic, and geographical issues you need to deal with in order to make survivorship successful. And a lot of that is guided by the oncology leadership and the hospital administrative leadership. So I hope you have a good relationship with them because they are going to be your allies in this process.
Yeah, oh, we do. We do, definitely. Good. Well, I appreciate all your input and your insight and your lessons learned. And
yeah, it's been a process, but I will tell you, it's a very valuable service, and the patients so appreciate it and have really gleaned a lot of benefit from it. And by the way, our COC survey went really well, and Dr. Fleischman was our COC surveyor, and he was very candid that he has not seen anything that even comes close to this program at any of the other centers he's gone to, and he really said that we were way ahead of the game, and this was the program to emulate. So it was very nice feedback, and they actually asked for an additional hard copy of one of these survivorship plans to take back to the COC committee.
Oh, nice.
Yeah, yeah. So, you know, I wish you all the best of luck. I will tell you it's been an absolute delight working with Elaine and her team. And they're professional, they're punctual, they're responsive, and she's very knowledgeable. And she's the type that has taken the ball and ran with it in terms of running interference with Cerner and the IT folks, as well as the tumor registry and data warehouse people. So I am pretty confident if I was working with another company, it would not have happened the way it's rolled out here. So I wish you all the best of luck. It's a fun journey. Just learn to be flexible. You need it for this type of thing. But I'm sure you all will do a great job.
Well, I appreciate your input. Thank you so much.
All right. Best of luck to all of you, and it was very nice meeting you.
Nice to meet you.
Bye-bye.
Thank you so much, Dr. Courier. Thank you.
My pleasure.
Okay, thank
Bye-bye.
Bye-bye.
Jennifer, did you want to stay on?
Yeah, does anybody else have anything?
We were just curious, what is the total, like, page length just on this standard form here? What number of pages were we at?
When you print it out for the student? So it depends on how much content you guys want to have. It's really actually up to you. The diagnosis is on one page and the treatment is on the second page. And then pretty much everything after that, like the visit schedule is on the third page. And then pretty much everything after that is up to you guys in terms of how much content you want to have. Because if you saw, most of it is patient education around first the surveillance, second is, patient education around persistent or long-term effects. And then the third is the late effects, and then the fourth is the wellness and prevention.
Okay.
They chose to have a lot of very patient-specific patient instructions embedded in the care plan instead of having a separate document for that. So the clinical plan, which is what we created to be used by other clinicians and for them to populate their note, is much more abbreviated because it doesn't have all that patient education.
Yeah.
And I assume that it's also customizable as far as the cancer resources, like the page that there was American Cancer Society and some different things, so we could gear that or edit that according to our county.
Yeah, so all of those are by disease. So if you have different resources for your prostate patients, maybe you have a prostate support group, that versus your breast cancer support group, or you have different leukemia and lymphoma support locally, like, the Leukemia and Lymphoma Society. All those are by disease. So you could have 3 for each disease, you could have 10 for each disease. It's really up to you guys. Also, we have gotten comments from patients that even though it's long, they actually do like it because it gives them everything in one place. And also the font is big enough for people who are, who have difficulty reading small fonts. So it's kind of that balance between not making it too long, but also making it readable.
And just in terms of, like, delivering this care plan, do you typically see a patient and a caregiver? Is it usually just a patient? I'm just wondering, whenever you're going over this electronically, is this like a desktop, or are you guys using, like, an iPad type thing? So everyone
I have, in each of our treatment rooms, we have a computer monitor, and I'm able to swivel it around. So I usually have the patient sitting in the examining chair, and then I'll turn the screen around and be able to, interact with the patient and show them, what's on the screen as I go through each of the different sections. But I don't use an iPad typically, but that would work too.
And I didn't know you were still on, Roz. Sorry. I was thinking that for you, because I thought you guys dropped off. The other thing that was really important for Dr. Courier was that she wanted to make sure that patients it was like shared decision making. So she wanted to make sure that patients felt like they kind of had input into their plan. And so that's why they're actually using it in the exam room, so that if Roz is saying, we have an exercise physiologist available for you, would you be willing to go see the exercise physiologist? That the patient is actually saying yes verbally, and then that gets put in their plan. So we're actually measuring right now, what is the acceptance of patients for some of these services, and then as patients accept them, are we going to see improvements in their outcomes over time?
I think just another comment that I have, just thinking about, in the room with the patient going through the information, I think they also really appreciate that sort of attention to detail and showing that we have, that we really know their cancer history and that we have all of this information. And oftentimes there are questions that they have about their diagnosis that maybe they haven't had answered, or there hasn't been time to kind of have some of those details clarified. So it is, in our setting, we have that time to really help them understand, if there's areas that they're not sure about in terms of the diagnosis or the treatments that they received.
And how long do you schedule for a patient to go over a Survivor plan?
The initial visit is an hour visit.
Okay.
So we're blocked for an hour for each new patient visit. And then a follow-up can be, often will be done in half an hour to 45 minutes.
And that's every 6 months, typically?
Again, it depends on the patient and how many issues they're having and whether it's a co-managed patient. So if I see a patient, for that initial visit and they're having a lot of side effects, or if they're, for example, very overweight and we're trying to work on the diet and exercise piece, I'll bring them back in 3 months to check back with them and, did they follow up on the referrals? How is it going? Just to have that continuity. But if it's somebody who's doing quite well and there's not a lot of issues, then I would make it a 6-month follow-up.
Oh, okay. What's this task button at the top here? Does that help you, like, if you've missed information or if you're going back in and editing and adding?
This button here?
Yes, ma'am.
That has information on care plans. Occasionally there's care plans that get opened and prepared, and then the patient if they didn't show for their visit, that would be one that I need to close out at some point. So that's information that's contained there.
Okay, but it doesn't alert you Miss Smith, need staging on her.
No.
Okay.
Is there anything else? Any other questions?
I don't have any at this point. Anna, do you have any?
No, I think it looks great.
Okay.
Okay, Elaine, I guess, if you want to share my email or work phone number, I'd be happy if you have, questions that come up after we finished. You can feel free to contact me, and I can, I'll absolutely do my best to answer any additional questions that you have.
Oh, that's so nice of you. Thank you so much, Roz. I really, really appreciate your time. I know you're really busy in your day-to-day job. And please, if Gladys can't hear me, please thank her as well.
I will.
Dr. Courier. Yeah. Okay.
All right, then.
All right. Thank you, everyone.
Okay, thank you very, very much. Really appreciate it.
You're very welcome.
Okay. Very helpful.
Okay, bye-bye.
Bye.
Thank you. Take care, team.
Thank you.
Bye, guys.
Bye.
Bye-bye.